Get started. My name is Dr. Tina Lewandowski, and I am the Director of Engagement. I'd like to thank you for attending today. Today we have a recorded presentation from Dr. Ryan Townley. He's an assistant professor in the Department of Neurology at the University of Kansas Medical Center, and he's the director of the Cognitive and Behavioral Neurology Fellowship. Dr. Townley's line of research seeks to understand atypical Alzheimer's, and his role at the ADRC allows him the rare opportunity to combine research with direct patient care. So we'll have a recorded presentation from Dr. Townley. Just a friendly reminder to keep your microphones on mute during the presentation. And after the presentation, we do have Annette with us. She's one of the study coordinators, and she'll be available for some questions. So I will go on ahead and turn it over to Brennan to start our presentation.
Thank you all for joining. I'm sorry I couldn't be there in person, but Thursday afternoons are my clinic day, so I wanted to record this and get this out to you guys. To raise awareness for Lewy body disease, actually October is Lewy body disease awareness month, so it's very apt that we have this on the first week of October. I also wanted to introduce our first Lewy body disease research study that we have going on for any of, if you guys know friends or family who have Lewy body disease, but also I wanted to introduce the idea that we have this Spark seminar to really have a 3-hour discussion on what is Lewy body disease. And so this is just a primer for all of that. So there's a lot to cover. I think it's important first to sort of define what we're talking about. And first we should define, who is Lewy? So there's actually Dr. Frederick Lewy he was a German-born neurologist, and he actually worked in the same lab that Dr. Alzheimer worked in back in the 1910, 1912 timeframe. And he discovered these Lewy bodies that we see under the microscope back in 1912. There was actually a large hiatus from sort of the early 1900s until the 1980s with regard to neuropathology. Part of this was because a lot of the neuropathologists that were studying brain tissue under the microscopes were in Europe, and we had World War I and II, and a lot of that work was sort of put on hold for many decades. This was pretty difficult to diagnose as far as Lewy body disease, and it was thought to be pretty rare up until the 1980s. There was a new staining technique that was developed to where we could see these Lewy bodies within neurons with a lot better ease. And then it was found in many of our brain banks that Lewy bodies were actually quite commonly present, even if they cause symptoms or not. So all of a sudden we're seeing that many patients have Lewy bodies, and it started to become more and more recognized clinically as well. We first formed consensus criteria for Lewy body dementia or dementia with Lewy bodies in 1996. And then that criteria has been most recently revised in 2017. And it's now recognized as the second most common cause of dementia, about 15 to 25%, but it is the most commonly missed one. And that's for many reasons, with one being just the lack of awareness of it, especially by non-specialists. The 2017 criteria to be able to diagnose this clinically requires at least 2 of the following core features. So the first one lists Parkinsonism. We'll kind of define Parkinsonism on the next slide. Visual hallucinations is a very common core feature, but I find that actually happens later in the disease course. One of the earliest symptoms is major fluctuations in cognition and alertness. So these fluctuations that are difficult to predict hour to hour rather than day to day. And then acting out dreams at nighttime is called REM sleep behavior disorder. So that's very common in this disorder as well. So you just need 2 of these 4. You can also diagnose this condition with just one of these core features, but plus an indicative biomarker. So indicative biomarkers are a certain DAT scan that shows reduction in dopamine cells, an abnormal REM sleep behavior study, basically documenting this core feature. And then we don't do this test in the States, but it's a cardiac scan. So Parkinsonism, what does that mean? Basically, there are 4 clinical features of Parkinson's disease. There's a rest tremor, classically starting on one side more than the other, although in my Lewy body patients, that is not the typical pattern I see. That slower movements, so we call this bradykinesia, but that's a very common early change that we see. Excessive slowness with walking and shuffling. Imbalance is part of that. So sometimes we just see unexplained falls being sort of one of the presenting Parkinsonism symptoms in Lewy body disease. And then stiffness and rigidity. So usually those are things we pick up on our neurologic exam. You only need one of these to at least meet the definition of Parkinsonism. In order to meet the diagnosis of Parkinson's disease, you have to have two of these features. Now, it's important to note that there are different causes of Parkinsonism. So if you have a stroke in the areas that are important for Parkinson's symptoms, you can have a vascular Parkinsonism. Patients that take dopamine blocking medications can have a medication-induced Parkinsonism. And then there are actually some unrelated neurodegenerative diseases like PSP or CBD that can cause Parkinsonism. What we're more focusing on today and in the talks about Lewy body disease are in the realm of synucleinopathies. So I mentioned that Lewy body earlier, it's made up of alpha-synuclein protein. And so synucleinopathies include multiple system atrophy, Parkinson's disease, which can progress in some patients to Parkinson's disease, dementia, and dementia with Lewy bodies. Now, it's this group of disorders that is grouped under this umbrella called Lewy body dementia, and that's really what we're focusing on today. All right, so you can kind of ignore these other causes of Parkinsonism for today. Parkinson's, I very commonly get the question, even from providers, what's kind of the difference between Parkinson's disease and Lewy body disease? I really think of these as a spectrum because they're both caused by the same protein in the brain, that alpha-synuclein that I mentioned. And it's true that a patient can walk into my clinic with no cognitive concerns at all, but they've got slowness of movements, they've got a tremor, they've got Parkinson's disease. That's kind of like a pure motor syndrome in some patients. There are other patients, and so I should note that some patients, my grandmother had Parkinson's disease, and it really took over 20 years of Parkinson's symptoms before she even developed any cognitive concerns. And we can see the other end of the spectrum. Patients can have visual hallucinations, cognitive fluctuations with no Parkinsonism, and they can be diagnosed with dementia with Lewy bodies. And actually 25% of these individuals may never get clear Parkinson's symptoms. Now, those are the two ends of the extreme of that spectrum, right? I would argue that a good 80% of my patients have a mixture of motor and cognitive symptoms. Really, it depends on where the alpha-synuclein is in the brain, of what symptoms one has. So there's a timeline with any neurodegenerative disease. You've heard this in other talks with Alzheimer's, where we're seeing amyloid changes years before someone develops cognitive symptoms. Well, the same is true in Lewy body disease. There's all these prodromal symptoms that in retrospect we find. There's this, I mentioned this RBD is REM sleep behavior disorder, or acting out dreams at nighttime. And then there's decreased sense of smell, autonomic symptoms of constipation, lightheadedness upon standing, erectile dysfunction, an odd one of increased runny nose after eating, temperature regulation issues. These can happen very classically 5 to 10 years before clear cognitive symptoms. I've had a couple patients where it's been decades of symptoms. And so I don't know quite how to rectify that, but just basically know that there are symptoms that are occurring systemically before clear cognitive changes are recognized. And then there's certainly a mild cognitive impairment stage. So, you'll hear this term dementia with Lewy bodies, and the current clinical criteria requires dementia to be present before you can definitively diagnose it. But on the research side, and those of us that specialize in Lewy body disease, we absolutely can diagnose this in a mild cognitive impairment stage. It tends to be different than a classic Alzheimer's disease. It's not the short-term memory impairments or what we call amnestic mild cognitive impairment. It's in this non-amnestic domain. Findings where visual spatial can very commonly be the difficulties, judging distances, inability to draw a cube and clock on our exams. Executive dysfunction is a major one, and attention difficulties. And then that dementia stage is where we look at those 4 clinical features. And certainly when somebody reaches that stage, it's a little bit more clear when the diagnosis is made. And we see these stages neuropathologically. So Brock are very famous neuropathologists, and they've sort of chronicled this sort of progression that seems to start with alpha-synuclein or Lewy bodies developing in the brainstem initially, maybe when some of the autonomic and REM sleep behavior disorder symptoms start, and then they start to progress cortically, and certainly by the time they're clearly in the cortex, there's significant cognitive changes and visual hallucinations with the back part of the brain involved. I will tell you that this is not true for every patient. Some patients actually start with cortical Lewy bodies. And so while this is a helpful schematic, it's not true in every patient as far as that progression. I should introduce this term because I'm going to have some slides on this next. So, what is a neurotransmitter? This is a neuron, this is a neuron, and these are axons coming out. They talk to each other. So neurons talk to each other. That's how they communicate. They communicate through a variety of ways, but one of the main ways is through a chemical called a neurotransmitter. And so within these synaptic clefts, you get a release of a neurotransmitter from one end of the neuron, and then it basically communicates with the next neuron through this neurotransmitter. And so there's different types called acetylcholine and dopamine and serotonin. So at the end of those neurotransmitters, so the cell would be up here, and this is basically that synaptic cleft here. Alpha-synuclein, labeled in pink here, is one of the important proteins within our cells that helps us get these little vesicles out to the end of the cell and to the end of that synaptic cleft, and then releases the neurotransmitter out into the area to start to communicate with the other cell, the one that would be down here. And this is just showing you dopamine. Alpha-synuclein is very highly prevalent in neurons that are important for dopamine release. And so this is basically helping these nerve cells talk to each other. Now, we know if we have mouse models and we have ways to sort of prevent alpha-synuclein from being present, which is depicted here in B, there's not as much dopamine. It is a problem. The vesicles can't traffic as well to the end of the nerve terminal, and there's the absence of alpha-synuclein is bad for the cells. But what we also know is that abnormal alpha-synuclein, when it starts to clump up, sort of shown in this on the C area, when they aggregate together, they're also blocking the normal transmission and release of dopamine. And this is harmful for the cell too. And the cell can actually die because of this sort of buildup and problem that we see. And so we have this idea of a loss of function and gain of function. In the interest of time, I'm not going to spend too much time on this, but essentially there's this idea that these proteins start to, when they aggregate, they start to influence surrounding alpha-synuclein, and then there's suspicion that this sort of leaks out, especially when the cell dies, and it spreads to the next cell, and that's how the progression of this disease manifests. And so we tried to stop the spreading with certain anti-alpha-synuclein drugs. Those have so far failed, and that may not be the right approach because we obviously have alpha-synuclein as an important protein for the cells as well. But there's a lot of research that needs to be done on that. We know in Lewy body disease in particular, there's a lot of different neurotransmitters that get affected. One of the main ones is called acetylcholine. This is an important cognitive neurotransmitter that has regions in the brainstem and in areas connected to the brainstem that we see cellular damage in Lewy body disease. We also see changes in dopamine, which again originate a lot of those projections out into the brain, down in the brainstem. We see this in serotonin as well, which is an important neurotransmitter for mood and apathy, anxiety, and depression. Again, a lot of those originating neuron projections are in the brainstem. And so I'm not going to go through all this because this is a much more detailed conversation for the Spark conference on October 15th. But one of the main ones that we see is acetylcholine that contributes to these fluctuating cognitive symptoms, sometimes what we call Lewy body spells. And we see benefit with medications that supplement acetylcholine or basically help keep acetylcholine around longer. And so these are just kind of like some of the cognitive symptoms we see in Lewy body disease related to this specific neurotransmitter. And there's this idea, so like patients can start to interpret this visual misidentification where this looks like a face. This looks like a face. All of a sudden there's a person in the wall, right? And that's where those visual hallucinations start to arise from. So all this is to really highlight too that Lewy body disease is not just a brain disease, it's a systemic disease. So we see all sorts of autonomic dysfunction. The autonomic nervous system is important for blood pressure regulation. It's important for maintaining an erection. It's important for urinary symptoms and sort of that stimulation of the bladder. It's important for stimulating the gut. And so there's a lot of autonomic symptoms. There's all the cognitive symptoms we've already talked about. There's the motor symptoms we talked about, this Parkinsonism. I've never seen a patient with Lewy body disease that doesn't have a sleep disorder. The majority have this acting out dreams at nighttime. I mean, it's part of the criteria. If you've got it, it helps diagnose it. But there's many other sleep-related problems that have overlaps with Lewy body disease. And certainly you can have these without Lewy body disease, but it's very common in those patients. Neuropsychiatric features, we've talked about some of these with sort of the hallmarks being visual hallucinations, sometimes misidentification syndromes as well. So because it's a systemic disease, we're actually looking into ways that we could potentially get a direct biomarker. And so one of these is through a skin biopsy. So we've tried a lot of different sites, and some of these are more sensitive than others, but as far as what's easily accessible and one that seems to be very predictive is actually just taking a small biopsy of the skin. And so this is kind of what this looks at. We can also measure this in the spinal fluid, but this one currently isn't covered by insurance, and so I rarely actually ordered that one. But we do have that available too. One that I'm a little bit more keen on ordering is this peripheral tissue biopsy, and we can look at the skin, the little skin biopsy that we get from the neck, the thigh, and the distal leg. We can look at it under the microscope, and we can detect that abnormal alpha-synuclein in the nerve terminals, those little nerves that are going down to the blood vessels within the skin. So just to give you a clinic example of this, this was an individual that we were kind of trying to differentiate between Alzheimer's disease and early Lewy body disease. We got a spinal fluid analysis, and I'm not going to bore you with the details of these numbers, but I will tell you that this basically suggests against an abnormal amyloid or tau. So it does not look like Alzheimer's disease. These are negative, and we can tell that from the spinal fluid analysis. But then the spinal fluid that we sent off for the alpha-synuclein showed abnormal aggregation. We also pursued skin biopsy in this individual, and it was positive in 2 of 3 sites. And so it was really helpful to get a confirmative diagnosis in this specific individual. So, wrap up the last few minutes here. Why is Lewy body disease so hard to study? I think, you could argue that cancer is very complicated, right? But one of the things with cancer is we can biopsy it, we can study the tissue, we can test treatments, we can find certain genetic mutations that we can target. But neurodegenerative diseases are more complicated. We can't biopsy the brain. That's frowned upon, right? Because it can cause damage. And much of what we learn is from autopsy, from brain donation, right? It's not something we want to talk about, but it's incredibly important to what we understand about these diseases. But even like studying someone's brain, right? That we're learning after the fact. We're not learning real time what's happening with the neurons as it happens. And so research on biomarkers are going to be important. We know there's a large overlap of Alzheimer's disease and Lewy body disease. For example, if we do an amyloid PET scan, which detects those amyloid plaques in the brain, it's positive in the majority of patients that have Lewy body disease. And that has its own impact on disease progression when you have more than one thing going on versus if you don't. And so being able to prognosticate for each individual, it would require us to know a lot more details than we can currently gather in many of our clinical encounters. KU is, as you have heard, it's a nationally and internationally recognized Alzheimer's disease research center, but it is not a Lewy body research center of excellence. We have never had a Lewy body disease study, and we didn't traditionally have a heavy population of Lewy body patients coming through our clinic. We were a pretty Alzheimer's focused clinic. With my training at Mayo Clinic, which was a Lewy body center of excellence, I've sort of brought some of that interest down here. And so these are sort of the criteria a center needs to apply for this Lewy Body Center of Excellence. And so, I sort of chronicled my first year of joining a few years ago, and roughly 25% of my patients were in that Lewy body disease category. And so that meets one criteria. We've got an excellent Lewy body disease patient support group. So that's through our cognitive care network team. That's another criteria. And now we are finally we're starting to get involved in clinical research trials. And so I will highlight that on the next slide. This is a clinical trial. It's looking for patients that have probable dementia with Lewy bodies, mild to moderate dementia. It's a phase 2 trial. We're just one of the sites that's involved. It's an oral pill formulation, and our goal is to at least enroll 10 individuals at our site. We actually have our first person enrolled as of last week. And so this is modifying the synaptic biology. This is also being tested in Alzheimer's disease. It actually blocks the toxic amyloid oligomers at the end of those synapses that I've showed you. And they're able to measure a bunch of different proteins in the spinal fluid, and we're seeing that many of these proteins are different in the placebo group versus the drug group. In the interest of time, I'm not going to show you too much here. This is basically just showing what I just told you, where we're finding that this drug compound, this CT182, when it binds to certain proteins along the outside of the cell, along the cell membrane, it displaces these amyloid oligomers. These are kind of like pre-plaques, and then it hopefully helps restore the communication between the two synapses here. And so this is the overview slide, contact information for our research study, right? Either for you, a loved one, or a friend, right? Giving them that information if they're interested. It's totally voluntary. This does involve a lumbar puncture. The part of this is because we're studying over 300 proteins before and after drug to see what modifications are we making. So we're learning a lot of information from that, even though it's not an exciting test, but it's something that is important with this study. It's not a very long study. It's about 7 months, but it does involve a number of visits. So again, if someone's interested, reach out to our team. We'll have one of our team members on after this to help answer any questions specifically about the study. If you have questions regarding Lewy body disease, that is not for my research team to answer. That's really more for me to answer. And I apologize, I'm not here in person, but bring those questions, write them down, bring them to the Spark event that we have going on. There's very likely that I will answer those questions in a more detailed setting with the Spark event. So here's some information for that. This one, that's because it's Lewy Body Disease Awareness Month. This one's actually not just for professionals that see patients. This is for families. So it's for the community, for caregivers, for providers. We do this on Zoom, so it's virtual. And this is going to be held on Saturday, October 15th from 9:30 to noon. The way this goes is we generally have an introduction, then we play the 45-minute documentary made by Robin Williams' wife, Susan Schneider Williams, along with the Lewy Body Association. And then we have an educational program on recognizing, diagnosing, and treating Lewy body disease. And there will be question and answer sessions with myself and Michelle Needens from our Cognitive Care Network team. So with that, again, I thank you for joining us for this important topic. And hopefully this was helpful for you all, and feedback will be much appreciated. Again, thank you.
All right, thank you so much for listening to Dr. Townley's presentation. I have Annette here with me, and she can help answer some of the questions that you may have about the Shimmer COG 1201 study that we have going on. So if you have any questions, let me know.
But I missed out on some of the information because I had to take a phone call. I would be very interested in the Shimmer test because I do have Parkinsonism, and I've got the the genes that put me liable for Lewy body, and my dad he died from Lewy body, and I am having, from the Parkinsonism, I'm having a lot of those weird things with temperature regulation and some cognitive decline. And every time I've tried to get into research with you guys, I've always been said, well, you don't qualify because you've got the Parkinsonism. And so I'm just trying to figure out, is this something that I would qualify for?
You want to take that one or not?
In order to qualify for it, you have to have a diagnosis of dementia with Lewy body, either mild or moderate.
Okay, so how can one get something like that? I know they're going to be doing skin biopsies to do the alpha-synuclein test fairly soon, but that's more part of research, I believe. So I don't know how that, but how can one get a diagnosis of the Lewy body if that's something that, or who would do that?
So you would need to see a clinician to do that, a neurologist to do that.
Okay. Is that something that, you guys do, or would Dr. Powell be able to do that?
I'm not sure.
I believe you could get a referral for a neurologist, or if you're already seeing a neurologist, then they would be able to make that diagnosis. And once we have that diagnosis, then we could see about continuing on with the screening process for you to participate in research in this particular study.
Okay.
So I would say once you get that diagnosis, then give us a call and we will work with you to get the medical records, and then we'll pass you off to the study coordinator, and then they'll start your meetings.
Okay. Thank you.
You bet. All right, let's see. It looks like maybe we've got another question. Is the study reevaluating the psychiatric medications that disqualify LBD patients with psychiatric symptoms?
That's a really good question. There are some medications that are not allowed in the study. And so what we would do is we would take a list of the medication. We would take a look at the medications that you're on and see whether or not those medications are allowed in the study or not. But there are some medications that are not allowed in the study.
And then Amy, who is our brain health navigator, posted in the chat that Dr. Powell could possibly give the diagnosis, or he may refer on to Dr. Townley for that diagnosis. And Dr. Townley who just gave that presentation. And so Dr. Townley would definitely talk about the Shimmer COG 1201 study. As with Dr. Powell, we've made sure that he has all of the information about the study as well.